Okay, so we can start. In this session, I have compiled questions from Anatomy and Biochemistry from the recently concluded FMGE exam. Right. So again, just to make presentation more interesting, I have removed the options, and we will just simply go with the question statements. Right. So the very first question is from Anatomy, where the question was about cutaneous sensation of the little finger and the medial half of the ring finger over volar aspect of hand is supplied by or is provided by which nerve. Now I think this is a very basic question which has been taught to you right from your initial days. So it's like volar aspect, clear, and this is little finger and the medial half of ring finger, clear. So this is commonly taught as 1.5. So 1.5 on the volar aspect of hand is all territory of, I think all of can answer this. This is ulnar nerve, clear. So this is the territory of ulnar nerve. So you can write medial 1.5. Clear. So when medial 1.5 over the volar aspect of the hand, it gets cutaneous innervation by ulnar nerve. Right. So that's very basic question, and I think there is no scope of error in such questions. Now this is a very interesting question and seen for the first time in an image based format. Now what is shown in the image? Now what you can see here, like you can see something written as axon, right? Some words like intron, then you can find some more keywords like 5' cap, then 3' poly A tail, and lastly you can see mRNA, right? So any idea what is this being shown on the image? Now initially what we see, there are both axon and say introns, right? So again we can, like, there is one more axon like this, okay, then there is one more intron like this. Now what is what is occurring ultimately, that only this axon part is coming here. So if I write like axon 1, say this is axon 2, so finally we are having axon 1, axon 2 like this. So what is being removed from here? The introns are being removed. So say intron 1, intron 2. So this is removed, and finally the mRNA which we are getting here, it is only composed of the axons. So what is this? This is known as RNA splicing. Okay, what is this known as? RNA splicing. And here the unnecessary material in the form of introns is removed, and only the coding part, that is the axon, it remains within the mRNA, because we know that from mRNA what is being synthesized? From mRNA there is formation of proteins, and this process is known as translation. Clear? So what is happening now? This is pre-mRNA. The segment of the RNA or the mRNA which is being derived from the DNA by the process of what we call transcription. Okay. DNA to mRNA is transcription, and then mRNA to proteins is translation. So initially what happens, there is formation of pre-mRNA. Now this pre-mRNA is not the purest one. Now what happens, there are some post transcriptional modifications. So post transcriptional modifications, and one of the modification is RNA splicing, the other two are capping of the 5' end and the poly A tail at the 3' end. So, to protect it from the enzymatic damage. So, these are the three post transcriptional modification. One is RNA splicing, another is capping 5' end, and third one is the tail at the 3' end. And since this tail is having many A bases, so it is known as poly A tail, right. So, this is known as poly A tail because it is having many A bases. So, these are all post transcriptional modification, and ultimately we have a mature mRNA which is then sent into the cytoplasm for translation process, right. So, in this particular image what we can see that the introns, right, these are the introns here, these are the introns, and these introns are then removed and only the exons are being incorporated into the mature mRNA. So, only the exons are coming here. So, this is exon, this is exon, this is exon, and the introns, they are removed, right. So, this is intron. So, this is RNA splicing, clear, one of the post transcription modification. Then next question from anatomy. Now, I have just mixed up the questions so that it makes the presentation a little interesting. Now, patient is unable to flex the hip. Okay. So, patient is unable to flex the hip and he is unable to flex the knee following injury to the anterior thigh. Now, which muscle is injured, right. So, here what keywords are being given to us? There is injury to anterior thigh. Okay. So, there is injury to anterior thigh and there is some injury to some muscle, and because of injury to this muscle the patient can't do flexion of hip and he can't do flexion of knee. So, we have to think of a muscle which is causing flexion of the hip and which is also causing flexion of the knee. So, the only anterior compartment muscle of the thigh which causes flexion of hip and flexion of knee is sartorius. Clear? So, this muscle is sartorius, also known as Taylor's muscle, and suppose if you want to sit cross-legged on floor, we need this muscle because it originates above the, right. So, the origin is above the hip joint. This sartorius, it originates above the hip joint from anterior superior iliac spine and it inserts below the hip, below the knee joint, right. So, on the medial part of upper tibia, clear. So, what it is doing, it is actually spanning two joints. And what are those two joints? Hip joint and knee joint, and therefore, it is causing flexion of the hip joint and flexion of the knee joint, right. So, therefore, if there is injury to any muscle of the anterior compartment of the thigh where the patient finds difficulty in flexing the hip and flexing the knee, the answer has to be sartorius. And particularly if we talk about the hip joint, the action you can remember as Faber. Clear? So, the action can be remembered by the term Faber, where F is flexion of the hip joint, AB is abduction of the hip joint, and ER is external rotation of the hip joint, right. And on knee it causes flexion and it helps us in sitting cross-legged position. So, this is cross-legged position, right. So, a very beautiful question, And the answer is sartorius. Chalo, next question. And now this is again from a very important topic. A 9-year-old boy having bleeding gums. The moment you find this word bleeding gums, 99.9% the answer has to be scurvy. Now here, apart from this particular hint, there is recurrent poor wound healing. That is also one more important feature related to scurvy. Then there are corkscrew hairs, swollen spongy gums. This is one more important point. And one radiological feature, that is white line at metaphysis. And the biochemical defect has been given. There is impaired hydroxylation of proline as it is needed during collagen synthesis. So it means there is defective collagen synthesis, and I think everyone can answer this. So there are plenty of keywords in this particular question, and so one is obviously bleeding gums. This itself singly is very sufficient to take us to the diagnosis of scurvy. Then there is swollen spongy gums, right? Then poor wound healing, and on X-ray we can see a white line of Frankel. So this is X-ray feature. So these all are classical for the diagnosis of scurvy, and we know that scurvy is because of deficiency of vitamin C. Now this vitamin C is needed, or it's a cofactor for the hydroxylation of proline and also hydroxylation of lysine. And the two enzymes which are needed here is prolyl hydroxylase, clear, and the second one is lyl hydroxylase. Okay, so this is very important here. So lysyl hydroxylase, okay, so just add a S here. So lysyl hydroxylase and prolyl hydroxylase are the two enzymes which are needed for hydroxylation of proline and lysine respectively, and this vitamin C is needed here. So if vitamin C is deficient, obviously this process cannot take place, and that's why there is poor synthesis of collagen, and that what leads to bleeding gums or capillary fragility, poor wound healing, right? So these are the classical features of scurvy. So I think there should be no scope of error in such questions. The next question, a patient presents with weakness of the lower half of the face on the right side, right? This is on the right side, but the patient has preserved forehead wrinkling. Now what is the most likely site of lesion? Now this is one question which has been repeated almost every year in one or other way in all exams, and for this I think most of you must be knowing that if we draw face something like this, so what we need to do, we need to divide the face like this. Now here there are two scenarios. If there is only involvement of the lower half of the face, or the other scenario can be again you will divide it into like this, okay. The other scenario can be this, like this one. So complete one half, where in this is forehead, right. So if there is any question about forehead sparing and only the lower part of the face paralyzed, this is upper motor neuron type of lesion. If there is very good Kakul, if there is complete paralysis of the one side, this is lower motor neuron type of facial palsy. Okay. Now what you need to remember here, when we say upper motor neuron, it is always contralateral, it is always contralateral. And when I say element, it is ipsilateral. Now, what I mean by the word contralateral, ipsilateral, suppose if the problem is on the right side of the patient, it means in upper motor neuron lesion, the lesion is on the left side. Okay. So, here it means the lesion is on the left side and the manifestations are seen on the right side. But in case of lower motor neuron lesion, the lesion is on the same side, that is right side. Okay. So, this is what you need to remember: upper motor neuron other side lesion and lower motor neuron same side lesion. And why the forehead is spared in the upper motor neuron? Because it receives bilateral corticobulbar innervation like this. So, even if one side is gone, the other side will take care. Okay. So, this is bilateral. So, if I draw it like this, so suppose if it is coming from here, it will go like this, it will go like this, okay, and like this. So, even if the right side is gone, even if this is gone, the left side is taking care. So, that is why the forehead is spared. Okay. So, that is very important. Forehead is spared, upper motor neuron, and there is involvement of the corticobulbar fibers on the opposite side, and lower motor neuron same side facial nerve palsy. So, that is what you should remember, and it has been asked many number of times. Please be good with this particular concept. It is very favorite for the exam setters. Chalo, next question. Now, what is the DNA repair mechanism defect in xeroderma pigmentosa? So, xeroderma pigmentosa, what is, so if we just write it about like xeroderma. So, as the name suggests, there is some problem with the skin. So, xeroderma pigmentosa or pigmentosum. Now, what is happening here? Actually, the UV light, it can cause some DNA damage. Clear? So, there is a repair mechanism. There is a repair mechanism to address this, and this is known as the nucleotide excision repair mechanism. And this take care of any DNA damage which has occurred because of UV light. But suppose if this mechanism is defective, what will happen? The DNA damage will continue to happen, right? And this lead to a condition that is known as xeroderma pigmentosa, where there is high possibility of UV light induced skin cancers, because the repair mechanism is not happening. So, it can lead to skin cancer like basal cell carcinoma or squamous cell carcinoma. Clear? So, this is xeroderma pigmentosa. Again, the word relate to derma. So, here you can associate with this skin cancers possibility, and that is induced by ultraviolet light. Clear? So, that is very beautiful description of xeroderma pigmentosa. Please remember this, and it is very favorite. Defective nucleotide excision repair. Right? So, the answer to this will be nucleotide excision repair defect, NER. So, this lead to xeroderma pigmentosa. Now, moving forward to another question. Now, a 6-month-old, now this age is very important in this particular question. 6-month-old infant develops vomiting after taking fruit juice. Now, what is the problem, or what is the sugar which is most likely? Very good, Sunny Bunny, very good, you are absolutely right. Now, here let us take the keywords first, because there are very good keywords which are given in this particular question, and this will help you in remembering the answer for long. So 6-month-old, number 1. Then there is the child has taken fruit juice, and the infant has taken fruit juice, and after that he developed vomiting. So it means the child is not tolerating fruit juice. Clear? And in fruit juice there is fructose. So it means the infant is not tolerating fructose, and this condition is known as hereditary fructose intolerance. Okay, so this condition is known as hereditary fructose intolerance, and this is because of deficiency of the enzyme aldolase B. So this is what you need to remember for this particular condition. Fructose, sucrose, the patient is not able to tolerate that, and that leads to symptoms. Now here this age is very important, 6-month-old, because what happens, there is one concept which we teach the student, exclusive breastfeeding, and the recommended is 6 months. So till the age of 6 months we have to breastfeed the baby exclusively. He should be breastfed, right? After 6 months you can start some complementary foods or some something else, and that is known as weaning. Clear? So this is known as weaning. So when the baby is taken off the breast milk and is given some outer food products, that is known as weaning, and therefore classically the age is given 6 months. So not tolerating fruit juice, it means he is not tolerating fructose, and that condition is hereditary fructose intolerance, which is because of deficiency of aldolase B. Clear? And there is defective metabolism of fructose 1 phosphate. Clear? So please remember this, very important condition from exam point of view, hereditary fructose intolerance, deficiency of aldolase B. Chalo, next question. A newborn presents with hypoplasia of zygomatic bones, right? I think all of you must be knowing the zygomatic bones on the lateral aspect of the face, then micrognathia, then malformed external ears and downward slanting palpebral fissure. Now this results from abnormal development of which pharyngeal arch? Okay, so let us write the keywords first. Now here the child is having hypoplasia of zygomatic bone. Okay, then micrognathia. Micrognathia means small lower jaw. Okay, small lower jaw. Then the third is malformed external ear, and usually they are small, and this is known as microtia. Right? Micro means small. So small ears. So this all condition is actually Treacher-Collins syndrome. Right? So this is a classical description of this particular entity, that is known as Treacher-Collins syndrome, and this is because of the first and second pharyngeal arch derivatives defect. So this is abnormal development of both first as well as second pharyngeal arch derivatives, right? So abnormal development. Clear? So Treacher-Collins syndrome, first and second pharyngeal arch abnormal development, and very easy, small jaw, small ear, that is microtia or micrognathia. So also you can find the word micro here. Chalo, next question. which amino acid forms disulfide bonds in keratin and therefore contributing to hair strength. So what is happening, like keratin disulfide bonds. Now this is because of cysteine, and cysteine, it is sulfhydryl group containing amino acid, and therefore if there are two cysteine amino acids nearby, in between them there will be disulfide bond, right. So this is because it is sulfhydryl group containing amino acid, so it helps in formation of disulfide bonds, and that gives strength to the keratin in the hair. And more the disulfide bonds, the more will be the stronger will be the hairs, and the curls, the hairs will be more curly as well. Okay, so that's very important. So more disulfide bonds, more strength, and more curliness of the hair. So that's keratin, very important from hair point of view. Then next question, a patient sustains a deep laceration over the eyebrow. Now separation of the wound margin occur due to injury to the which layer of the scalp? Now separation, actually the exact word is gaping, right. So gaping means opening up of the wound. So in simpler terms you can call it opening up of the wound. Now to answer this particular question, you have to recall the layers of the scalp, which can be remembered by the mnemonic scalp itself. So if we just write scalp something like this, so S is skin, C is deep connective tissue, okay, A is aponeurosis, L is loose connective tissue, and P is pericranium. Peri means surrounding, so it is surrounding the skull. Now out of all these layers, this aponeurosis is very important. Now why it is important? Because what happens, like suppose this is aponeurosis, which is also known as Galea aponeurotica. On the posterior side there is one muscle, and on the anterior side there is one muscle. The posterior muscle is occipitalis and the anterior one is frontalis. Clear? So what happens, suppose if there is an injury something like this, so the frontalis will pull it anteriorly and the occipitalis will pull it posteriorly, and the wound will open up. So the wound will open up something like this. So if there is any injury to the scalp or say forehead region, if there is any injury something like that, the opening or gaping will only occur if the aponeurosis is divided. Clear? If it is divided, then obviously this end will go here, this end will go here, and there will be gaping or opening of the wound margins. So that is because these two muscles, they are pulling the portion of the aponeurosis towards their side, and that was causes the opening of the wound margin. So gaping of wound margin of scalp, particularly if there is involvement of aponeurosis, which is also known as Galea aponeurotica. Clear? That's very important. So layers of scalp. Now a 45-year-old woman develops difficulty in producing high pitch sound, and there is a history of, like, she is a post-operative case of thyroid surgery. Now which nerve is injured here? Sunny Bunny, very good, you are absolutely right. Now here let us take the anatomical concept first. Now high pitch sound. High pitch sound is produced when the vocal cords are tensed or lengthened, right. So it means they have to be tensed. So the tensor muscle is important here, and the tensor muscle is cricothyroid. Now remember, a muscle will never paralyze by itself. It is if the nerve supply is paralyzed. So if the nerve supply is gone, then only this muscle will get paralyzed. There will be no tensor effect, and therefore there will be no high pitch sound. Now the question is indirectly asking about the nerve supply of cricothyroid, and as Sunny Bunny rightly answered, this is external branch of superior laryngeal nerve. Clear? So external branch of superior laryngeal nerve. Now I think if you have read about muscles, the nerve supply of the intrinsic muscles of the larynx, that all the intrinsic muscle of the larynx are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve. Okay, so that is the basic concept, which is very beautifully framed and then asked. So if you know the answer, if you know the action of cricothyroid, you can easily, and obviously the nerve supply of cricothyroid, you can easily answer this type of question. So high pitch sound, the vocal cords have to be tensed, and the tensor of vocal cord is cricothyroid, which is supplied by external branch of laryngeal nerve, superior laryngeal nerve. Very good, Sunny Bunny. Chalo, next question. Again a very basic question and has been repeated many number of times. A patient comes with megaloblastic anemia plus neurological symptoms. Now which vitamin deficiency you can think of? Now here megaloblastic anemia, I think there are, everyone must be knowing that there are two reasons. Either there can be deficiency of vitamin B12 or there can be deficiency of folic acid. Now if very good Kakul, if we take this neurological symptoms, it is only associated here and it is not seen here, right. So megaloblastic anemia plus neurological deficit, the answer has to be vitamin B12 deficiency, and therefore this is many times asked in a clinical manner, that if a patient is having megaloblastic anemia plus neurological symptoms, then don't give folic acid alone. You have to give vitamin B12 also, because the neurological symptoms will not recover if you give only folic acid. So folic acid, so like treatment wise, if we give folic acid alone, suppose if this is the scenario, so what will happen? Megaloblastic anemia will correct. It will correct, but the neurological deficit will worsen. And why it will worsen? Because the cause of neurological deficit is what? Vitamin B12 deficiency. And what you are giving? You are giving only folic acid. So it will not respond to folic acid alone. And here you have to give vitamin B12, then only the neurological deficit will also improve. So folic acid alone should not be given in a case who is having megaloblastic anemia as well as neurological symptoms. In such cases, you have to give vitamin B12 and not only folic acid. Clear? So that's a very beautiful correlation of this particular concept and has been asked in many different ways. But what you need to remember now, that if there is megaloblastic anemia plus neurological symptoms, always think of vitamin B12 deficiency. And here in this regard, there is one term that everyone should know, that is subacute combined degeneration of spinal cord. So that is subacute combined degeneration of spinal cord. Clear? And there is affection of dorsal column. Clear? Chalo, very good. Chalo, moving forward. Now a patient is unable to extend the fingers while the wrist extension is preserved, and there is fracture of the neck of radius. Now which nerve is injured here? Now that's a very beautiful question. Now what actually is given here? Let us write. Inability to extend fingers. Clear? But wrist extension is present, right? And there is a fracture neck of radius. Now what will happen here? Now let us take this one by one. Okay, suppose you don't know any nerve relation to fracture neck of radius, no problem. We can take this keywords and then we can reach up to the answer. So inability to extend fingers, it means no extension at metacarpophalangeal joint. It means there is no extension at the metacarpophalangeal joint. Now you have to think of the muscles paralyzed, right? Because extension at the MCP is carried by muscles only. So it means if the muscles are paralyzed, that's why the patient is not able to extend fingers. Now what are those muscles? One is extensor digiti minimi, going to the little finger. Then going to the index finger is extensor indicis, and going to the all finger is extensor digitorum. Clear? So these are the muscles which are digiti minimi for little finger, indicis is for index finger, and digitorum is for all the four fingers. Now what is happening? These muscles are paralyzed, and as I told you before, muscles cannot be paralyzed by itself. It is the nerve supply which is paralyzed. Now what is the nerve supply of these three muscles? Extensor digiti minimi, extensor indicis, extensor digitorum. Now the nerve supply to these three muscles is PIN. PIN. And PIN stands for posterior intraosseous nerve. Okay, so this is how you will remember this beautiful concept of finger drop, where there is no extension at the MCP joint, the finger they remains flexed, and it means the muscles which were supposed to extend them are paralyzed because the parent nerve of those muscles is damaged. And yes, this PIN is very closely related to the neck of radius. Therefore, if there is any fracture of the neck of radius, it will injure PIN. And in relation to this, you should know one muscle also, that is supinator. So this muscle passes through the supinator muscle, this nerve passes through the supinator muscle, and therefore whenever we are operating somewhere around the area of neck of radius, we have to retract this muscle properly so that it does not come into the operative field. Otherwise, next morning you will see a patient with finger drop. So that's a very beautiful concept, and yes, I think it might be very difficult for you because it's all clinical, and yes, it's being taught in orthopedics but integrated with anatomy very beautifully. Chalo, next question. A patient 2-year-old is having delayed wound healing. Now this is about deficiency of micronutrient, because delayed wound healing, previously we discussed one vitamin related to this, and this was vitamin C deficiency. Now this question is about the micronutrient, and that micronutrient is actually yes, vitamin is okay, vitamin is vitamin C, but this is micronutrient, and micronutrient is zinc. Okay, so the micronutrient is zinc. So for this particular question, either the answer will be vitamin C or the answer will be zinc. So delayed wound healing. Next question. A patient undergoes parotid gland surgery and subsequently he develops loss of cutaneous sensation in which area? Angle of mandible and lower part of external ear. Which nerve is injured? So now again this is an anatomical fact based question. If you know the statement or if you know the fact, you can answer this, otherwise it will be very difficult. Now it's a known case of parotid gland surgery, and then after this there is injury to some nerve, right? So there is injury to some nerve, and as a result of this there is loss of sensations. Now in which area? Angle of mandible, that's very important. Angle of mandible and lower part of external ear. You can say pinna. So now here the examiner is actually asking you whether you know the nerve supply or the cutaneous nerve supply at the area of angle of mandible or the lower part of external ear. If you know that, you can answer this, right? So that nerve is great auricular nerve, right? So that nerve which is supplying the skin over the parotid area, right? So here we can write parotid area also. So this much area is supplied by great auricular nerve. Okay, this is great auricular nerve. So it is supplying three important areas: angle of mandible, lower part of pinna, and third skin over parotid gland. So this is great auricular nerve, right? So please remember great auricular nerve. Now the examiners are very fond of this particular nerve. Please remember it, great auricular nerve, very good, right? So if I just, like suppose this is the ear, this is like the angle of mandible, this is the parotid gland here. So this much area you can remember for great auricular nerve, something like this, okay? So great auricular nerve. Chalo, next question. Identify the type of suture marked with the black arrow in the given image. So you have to identify which suture is this. So you have to identify this suture. Now here let us take the label. This is the parietal bone, this is the temporal bone, right? This is the frontal bone, this is occipital, and this is sphenoid. Okay. Now the suture which is being asked in the question is between the suture is between the parietal bone and the temporal bone. Okay, so this suture is known as the squamous suture. Clear? So this suture is squamous suture, right? So this is squamous suture. Now here you can see this is the pterion, right? So the junction of four bones is the pterion, and I think most of you must be knowing the neurosurgical importance of pterion, that it is just behind that is middle meningeal artery. So and this is the weakest part of the skull. So if there is any fracture in this area, it can injure the middle meningeal artery, resulting in epidural or extradural hemorrhage. So squamous suture is lying behind an important landmark that is known as pterion. Clear? So this one is the pterion here. So you can remember it like this. Okay, so this is squamous suture, and very rare question has been asked, I think, for the very first time. Now, a child presents with dark urine and dark pigmentation of the ear cartilage. Which enzyme deficiency is responsible? Now, I think this question has been asked many number of times, and I haven't seen any paper in which this question is not included. So, whether it is FMGE, NEET, PG, INICT, everywhere they will put, yes, the level of difficulty is always that varies. So, what you see here, dark urine, and what you can see, dark pigmentation of ear cartilage, and this condition is known as ochronosis. This is known as ochronosis, and I think the moment you find this particular word, ochronosis, and darkening of urine, especially on exposure to atmosphere, these are the classical words which give you the hint that this question is about alkaptonuria. Clear? So, this condition is alkaptonuria, and alkaptonuria is because of deficiency of which enzyme? Very good, homogentisate oxidase. So, this is deficiency of homogentisate oxidase. Clear? And that's how, the moment you find any dark word, think of alkaptonuria, classical. Chalo, next question. 20-year-old man presents with intermittent, means off and on, mucoid discharge, something related to mucus, and there is a small opening which is along the lower third of the anterior border of the sternocleidomastoid muscle, and this is since childhood. This is because of persistence of which pharyngeal cleft. Now, here let us write the keywords first so that we can reach up to the diagnosis first, like this is which condition actually. So, there is intermittent, means on and off, sometimes it is there, sometimes patient feels normal. Mucoid discharge, there is a opening which is present at the lower third anterior border of which muscle? Sternocleidomastoid. Clear? So, this is sternocleidomastoid muscle. Now, this condition is actually branchial fistula. Again, so they have integrated a surgery question with anatomical facts. So, this is branchial fistula, and this is because of persistence of second pharyngeal cleft, right? And when we say fistula, it means a fistula has an inner opening and an outer opening. So, a fistula has to have two openings. So, the outer opening is already mentioned here. So, this is the outer opening, clear? And the inner opening is in the tonsillar fossa, clear? So, it is a fistulous tract. The outer opening is in the lower third anterior border of sternocleidomastoid. This is actually junction of upper 2/3 and lower 1/3 most appropriately in the anterior border of sternocleidomastoid, and the inner is in the tonsillar fossa. So, this condition is branchial fistula, which is related to the second pharyngeal cleft. Okay, chalo. Now, again a little difficult question because it's all image based question. So, we have to answer like which artery passes through the ligament marked as number 3. So, firstly you have to identify what is number 3. Now, number 3 ligament is connecting spleen, okay, So you can see this is spleen, right? So it is connecting spleen with the kidney, and obviously which kidney, right or left? It will be left, because spleen is on the left side. So this ligament is connecting spleen with the left kidney, and therefore the name of this ligament is what? You can call it splenorenal, that is one way, or the other term linorenal. Clear? So since it is connecting the two spleen, two structures like spleen and kidney, so you can call it a splenorenal or linorenal ligament. Now the question is, what artery or what vessels passes through this ligament? So this ligament gives way to ligament, the splenic artery, right? So what passes through this? Splenic artery, and also apart from this artery, it contains splenic vein and tail of pancreas. So it contains tail of pancreas, splenic vein, splenic artery, and this ligament is splenorenal or linorenal. Clear? So this is number 3. So that's the end of this session, and I hope you have enjoyed the session. I am very sorry for that technical glitch, and my my image is not visible on the screen, but nevertheless I think you must have enjoyed the content of this presentation, and very shortly I'll come up with some more subjects. Till then, keep on studying. God bless. Bye bye.